Pediatrics. I'm very excited to welcome you to our inaugural grand rounds of the new academic year. I'm really excited about the seminars that we have organized for this year, and I want to thank our Vice Chair for Education, Dr. Sandrain Van Schaik, for putting together such an outstanding seminar series for us this year. And with that, I'm going to turn it over to Sandrain to introduce our grand rounds for today.
Thank you, Dr. Hirsch, and too much credit. There's a whole committee behind this ingenious schedule coming up. And I'm very pleased to start it off with a session that gives us an update on COVID-19 and the impact of that COVID-19 is having on various different aspects of our patient care and our daily practice. We have 4 speakers lined up for you, and I'm going to introduce them all in one go, and then they will give their piece of the session one by one, followed by hopefully some opportunity for question and answers for the entire panel. So the first speaker is Dr. Linda Ramirez. She's an associate professor in the Department of Pediatrics, Division of Infectious Diseases and Global Health, where she serves as the medical director of hospital epidemiology and infection control at the UCSF Benioff Children's Hospital in San Francisco. She has played a lead role in leading our medical center's response to this pandemic, and I should actually say she has played a leading role in leading our medical center's response to this pandemic because she's really been at the forefront. Dr. Ted Ruel is our second speaker. He's the chief of the Division of Pediatric Infectious Diseases and Global Health and director of the Pediatric Infectious Diseases Fellowship Program. He is a clinical scientist whose research is focusing on treatment of children living with HIV, both domestically and globally. Our third speaker is Naomi Bardock. She's an associate professor of pediatrics and policy in the Department of Pediatrics and the Philip R. Lee Institute for Health Policy Studies at UCSF. She's vice chair of health services research in our department and also a primary care pediatrician at Zuckerberg San Francisco General Hospital. She's really started to focus on school reopening, looking at research and evidence-based public health. She's led studies on COVID-19 testing, and she's really becoming a national voice and can be heard and seen on radio stations, TV stations, articles in the New York Times and the Washington Post, so real celebrity in this area. And then our fourth speaker is Elizabeth Rogers, an associate professor in pediatrics and a neonatologist in our division of neonatology at Mission Bay. She's the director of the Root Small Baby program in neonatology, and she serves as the associate vice chair for faculty development and chief experience officer for the Department of Pediatrics. So I am really excited to hear from these 4 speakers, and we're going to kick it off with Dr. Ramirez, who will start the presentation.
Thank you, everyone, for the opportunity to review information about the epidemiology and transmission of SARS-CoV-2 in children. And to remind everyone, SARS-CoV-2 is the virus that causes COVID-19. So to date, there have been 26 million cases of COVID-19 reported in the world. In the US, we are the country with the most number of infections, currently at about 6 million cases. The infections in the US are currently concentrated in the Southwest and as well as the South. In terms of pediatric patients in the US, there have been about 475,000 cases reported thus far, and this represents about 9.5% of all COVID cases reported in the US. It's interesting that in August alone, there were about 155,000 pediatric patients that were reported, and this represents a third of all the infections in this population reported to date. And this might have to do with availability and testing strategies in the pediatric population. In terms of the numbers in California, we've had about 700,000 cases, which is the highest number reported in any state. Among children, there have been about 70,000 cases. So about 10% of our infections in California have happened in kids. California does report the highest number of absolute pediatric cases in the US. But if you look at the cases per capita, we report 800 cases per every 100,000 children. And this compares to the average rate of 600 cases per 100,000 children. So we are slightly above the national pediatric average. I just want to make mention that Latino children have disproportionately been affected by this pandemic. So although Latinos only make up 48% of the population, they account for 70% of the pediatric COVID cases. So I'm going to shift gears and talk about our own testing experience within our health system. So to date, within the pediatric population, we've done over 10,000 COVID tests, of which so far we've had about 475 positive results. If you look at, and that's represented here in the dark yellow, so those 475 positive results represents about 40% of all the positives reported in our health system, which is a number that I think is underappreciated. Overall, our pediatric test positivity rate is about 4.6%, as represented here in the overall number. If you look at the symptomatic and asymptomatic test positivity rates, they are higher in pediatrics than compared to our adult population. And in particular, BCH Oakland has been more affected by this pandemic than the West Bay campus, with a symptomatic test positivity rate of nearly 10% and an asymptomatic test positivity rate of 4.4%. Also available on our COVID data dashboard is the breakdown of COVID cases by age. And thus far, out of our 475 positive cases, the majority have been seen in children 1 to 5 years of age and those 11 to 17 years of age. A minority of our patients, only 9%, have been hospitalized due to their infection. I'm going to talk about transmission. I specifically wanted to spend some time discussing the difference between having a positive SARS-CoV PCR and having replication competent virus. I'm going to be using the term replication competent virus interchangeably with having culture positive virus, to draw your attention to that. So our SARS-CoV-2 PCR is our workhorse for diagnosing COVID-19. In terms of the viral kinetics, the viral load is usually detectable, or it is detectable around symptom onset, and it starts to decline in the first week, as shown here. This being time 0 from symptom onset, you can see from a nasal sample that you already have detectable virus, and that within the first week, it goes down. PCRs, very importantly, do not distinguish between live virus or replication competent virus and viral debris or dead virus. And I think that's an important point to take away from my presentation. The other concept I wanted to review is the concept of a cycle threshold. It basically is a measure of how much virus is present. And in particular, there's an inverse relationship. The lower your cycle threshold value is, it indicates a high viral load because it basically indicates the number of PCR cycles that are required to have a fluorescent signal, noting a positive result. So what have we learned in children? Since we last presented, which was a long while ago, there actually now is minimal, but some pediatric data looking at cycle thresholds in our population. So in particular, in a cohort of 145 patients that included 100 children, they looked at those that had mild to moderate illness, that had symptom onset within the last week and were diagnosed by a nasopharyngeal PCR. So what they found, and it's represented here in this figure, that children, especially those under 5 years of age, had lower cycle thresholds equating to more virus compared to older children and adults. And as you can see here, the 5 to 17-year-old age range and the adult population had comparable amounts of virus. It's really important to note that this study focused on PCR results and is not indicative or necessarily will correlate with infectious virus. The other thing I wanted to review is that patients who have recovered from COVID-19 can have persistently positive PCRs for a long time in certain cases. There are some reports that greater than 12 weeks have been reported, and I feel like there's even anecdotal reports of much longer than that. And there's also a subset of patients that have intermittent positive PCRs, which is thought to be most likely consistent with viral shedding. An important question that has been asked is whether these patients with persistent positive PCRs or intermittently positive PCRs are infectious to others. And I feel like an important study to be aware of is from the Korean CDC that looked at 285 persistently positive COVID-19 patients. And they looked at their contacts, and they reported that out of 790 contacts, there was no secondary infections attributed to that contact with that persistently positive person. They also attempted to recover replication competent virus from 108 of those patients and were not able to. In contrast to PCR, SARS-CoV-2 culture identifies infectious virus, and it turns out that this test is not widely available because of biosafety concerns. So a number of studies and the CDC have looked at how long a person with COVID can have virus cultured from different body sites. And in particular, the summary of those studies and the CDC's experience is as follows, that replication competent virus is not recoverable for patients with mild to moderate COVID disease after 10 days following symptom onset. And in patients with severe disease, inclusive of some with immunocompromising conditions, that you would not recover replication competent virus after 20 days following symptom onset. So the CDC has used this information to update their discontinuation of isolation criteria in the last weeks, and we are currently reviewing those recommendations, and we'll likely be making some changes to our own discontinuation of isolation criteria. I also wanted to just mention that a few studies have tried to correlate cycle thresholds and viral cultures. And one particular study reported that there was no viable virus obtained from samples with a cycle threshold of greater than or equal to 34. That's actually was also reported in an additional study. Viral cultures have been recently assessed in children, and in a cohort of 23 children, they found that about half of them, 12, had positive viral cultures, or once again, like I'm using the terms positive viral culture and replication competent virus interchangeably. The median age of that population was 12 years, with a range of 7 days to 16 years. And as you can see here from this figure from that paper, that patients who had positive SARS-CoV-2 cultures had higher viral loads as compared to those that had negative cultures. In that small number, 12 patients, they reported no correlation with age or symptoms. The last thing I'm going to cover is asymptomatic COVID-19 infections. In children, the spectrum of COVID-19 is comprehensive, but our experience to date shows that children are less likely to have severe disease and to die as a result of their infection. And the majority of kids, as a result, have mild infections or remain asymptomatic. So asymptomatic infections, very particularly, are defined as someone who has SARS-CoV-2 infection, but never develops symptoms in their disease course. That is different than pre-symptomatic patients, who are patients who are also infected, but eventually develop symptoms as a result of their infection. And that's different from patients who have sometimes very subtle, mild symptoms. Overall, this is a population that is difficult to study because there is a bias towards, as our testing capacity has changed over time, towards testing patients who are symptomatic, as well as once you do have a patient who is asymptomatic and has a positive test, you actually don't know when they actually became infected. You just have the time point of when they when they were diagnosed. So overall, thus far, the estimates for the contribution of asymptomatic COVID-19 infections is 40 to 45%. If you look at particular pediatric studies in trying to understand what fraction of COVID-19 children are asymptomatic, the estimates are quite wide, anywhere from 16 up to 45%. And one particular meta-analysis, which included about 1,100 children in 11 studies, showed an asymptomatic infection rate of about 28%. That being said, the estimates, as I alluded to, remain are quite uncertain for different reasons, including these studies have different definitions for what it means to be symptomatic. We talked about testing availability and also differences in longitudinal follow-up. So some studies follow patients for a week, some studies follow patients for longer. So you could imagine that depending on that time frame, there might be an opportunity to miss patients who go on to develop symptoms. So in terms of what we know about these asymptomatic COVID-infected patients, there have been a number of reports that have looked at cycle thresholds in asymptomatic and symptomatic patients and have reported comparable values. In addition, both adult and pediatric studies show a similar duration of viral shedding than symptomatic patients. And I just wanted to call attention to a specific a Korean cohort that looked at 91 children, of which 20 or 22% were fully asymptomatic during the follow-up period. The thing that's interesting about this study is that they followed patients longitudinally that were being kept in an isolation center as part of their public health approach. So they had a pretty good understanding of serial testing as well as follow-up over time. And what they reported amongst these children that were asymptomatic, that it takes on average 14 days for these asymptomatic patients to stop shedding virus, as compared to 18 days in patients with upper respiratory tract symptoms and 19 days in patients with lower respiratory tract symptoms. So suggestion of that there might be a difference, but that difference is likely small. There have been multiple epidemiologic reports supporting asymptomatic transmission. I just call attention to two specific reports. One that was reported in JAMA was a case report out of China of one asymptomatic person that seems to have infected 5 family members based on the reported timeline. There was another interesting study that I looked at from an Italian municipality that performed 2 surveys, including testing and post-interviews around a 14-day lockdown that they implemented when they had their first COVID diagnosis. And they report that 2 out of the 8 participants had, with new infections, 2 out of the 8 participants had new infections reported. And on secondary survey, those people had been in contact with asymptomatic individuals. Listed here is a reference that provides a more comprehensive a list of some of these epidemiologic reports. So I think the key question that's remaining is how infectious are asymptomatic COVID-infected people compared to those that are symptomatic? So are asymptomatic patients less likely to be infectious because they're not coughing or sneezing? How long do these asymptomatic patients have positive viral cultures? Does this information differ in the pediatric population? And really, in order to get a better handle on this question, there probably needs to be a consideration for a different type of study, including studies that are prospective, large, cohort-based, and that provide serial COVID-19 testing as well as very close follow-up for a defined period of time. That is the end of my slides.
Thanks so much, Dr. Ramirez. Handing it over to Dr. Ruel.
Okay, let me just get this going here. All right, we are being very fancy by allowing the speakers to control one screen, but just give me 1 second to transition. Here we go. Okay, looks like it's going, but Chloe, thank you, Lynn, for that. And we'll now turn to updates on clinical infections. So now we'll turn to symptomatic children and what have we learned since basically our last grand rounds in April. In March, just prior to when all this started, the first reports from China were suggesting that kind of symptomatic respiratory disease, which had been the predominant kind of syndrome associated with SARS-CoV-2, was less common and less severe in children. And then in April, we had a twist as cases were reported from Europe suggesting a distinct multi-system inflammatory syndrome in children that was following waves of primary infections in these communities and suggesting a kind of post-infectious inflammatory syndrome that shared some features with Kawasaki's disease. So where does that leave us now? I'd say both of these things are still true, but it's more complicated. There's a lot of nuance around that, and we'll touch on that a little bit now. The MMWR put out a report in the middle of last month with an update on hospitalization rates across the nation. You'll note that this is a report from a network in 14 states, and they summarized outcomes in 576 children. That's a small number compared to the EPI that Lynn presented, but it does underscore this is a subset for 14 states, but also that the number of children getting hospitalized is still low. The cumulative rate in this group was around 8 per 100,000 population, which really pales in comparison by a magnitude of 20 compared to adults in those same regions. A little under half of them had a comorbidity, of which obesity was the largest represented. And a couple things pulled out that I've highlighted in red. A full or near fifth of these kids were children less than 3 months. And this is a new thing that I think caught some by surprise. Infants early on and from the reports in China were representing small numbers, but this is a larger number than we had anticipated. And a third of these were admitted to the ICU. And I think that's something that we're going to have to unpack more from ongoing networks to understand which those cases are. But it does underscore that these kids are severely ill. That said, they had closer details of outcomes in a subset of a quarter of those, and among them, only one child, or 0.5%, has actually passed away. And I think this resonates with really a lot of the reports we've had from other hospitals in publications. Children can die, but it remains, thankfully, a pretty uncommon occurrence. So in the same issue, they also pulled out a series of MIS-C cases. And when these cases were first reported from Europe, the CDC developed its own case definition, which I highlight on the upper right there. Is meant to be very inclusive. So it's basically being a child, having fever for greater than a day with laboratory evidence of inflammation, being hospitalized, and having at least 2 organs involved in your presentation. So from any of the systems mentioned there. Not having an alternative diagnosing, having diagnosis either by direct isolation of the virus, not isolation, but RNA positivity, antigen test, or antibody, or a really compelling case of exposure. And the key findings to take up from this are they are older, around 8 years of age, which was what we had seen with the first MIS-C reports. About half were male. Worth noting that 46% were by serology, which kind of fit this profile of a post-infectious syndrome, but a quarter of them were just RNA. So it began to be a hint that maybe it's not so simple that children are falling in these 2 buckets of respiratory and MIS-C. Kind of recognizing that what they got when they did this case report was a much more complicated spectrum of diagnoses. They couldn't even structure their report around those 2 bins, and they realized they needed to kind of really unpack this data more carefully. They used a technique called latent class analysis to sort these cases and kind of organize them into 3 bins. One, which is kind of a multi-system involvement syndrome, kind of like the original MIS-Cs. And of those, coronary artery disease was found in 21%. Some had just respiratory presentation, but also, unfortunately, and somewhat kind of surprisingly, had coronary artery disease as well. along with the inflammation. And then some had more of a classic, what was called the Kawasaki's disease-like presentations with rash and mucocutaneous disorders. So really, I think a really important report which shows us that we can't treat kids like they're in these two bins. They're going to present a diversity of ways, and we knew that there were multi-system involvement with adults, but I don't think it's nowhere near the kind of overlapping spectrum we're seeing with children. And we're really going to have to be thoughtful as we evaluate these. And I'd say in the limited case experience we've had at Oakland and here at the West Bay campus has said this. Almost none of them have been classic cases. They've all had these kind of funny different features which reflect the different ways this virus can present. This virus is so clearly not just a respiratory virus. I think we really, in adult and pediatric cases, we're really learning that it is a full body phenomenon, a lot driven by inflammation and not direct pathology, but we're still learning a lot, and we're going to learn a lot with a longer follow-up. And I call it the heart disease here as mentioned on the slide, but another important paper came out that was brought up in our working group that showed that in a study of, I think it was 100 adults, they looked at kind of MR at the heart and found myocarditis in a large proportion of them. So I think we're really going to have a lot to learn as we follow the cases in children. Okay, another important thing to pull out from both these reports is that racial and ethnic disparities with COVID are really pronounced in children just as they are in adults. Kind of using CDC terminology, Hispanic children were at 8 times higher rates of hospitalization than white children, and Black children were 5 times that rate. And then also specifically within the MASC cases, Hispanic and Black patients accounted for the largest portion, 75%. The predominant explanation for this is still one of exposure and risk. These are the children whose parents are working in the service industry and don't have access to the preventative measures either in their home place or often in workplace. But important nonetheless to recognize as we try to address this epidemic, both in hospitals and in our prevention efforts and to support these populations. A couple other highlights that have changed. Early on, we were mostly doubting vertical transmission because they hadn't seen that many cases. And a lot of the cases, it was hard and still to untangle what is immediate postpartum exposure from a symptomatic mother to her infant versus a true perinatal infection. But there have been a couple reports which are hard to discount anymore. The first is listed there. This is a 35-week gestational age, born by C-section with no rupture membrane, so no potential exposure theoretically prior to that. They documented maternal viremia, placental histopathology with high viral loads and inflammation, and then neonatal viremia as well. So really kind of triangulating around a strong case for intrauterine infection. I show some of the slides and numbers there, but the bottom line is, finding it in all fluids and suggesting this child really did have a prepartum exposure. That child also had symptomatic neurologic disease. And then the second case, just to pull out here, was a 38-weeker. This was actually reported from, I think the first was in the US, the second one was international. Also C-section, also no rupture membranes, it was from Mexico. RNA positive from nasopharynx and oropharynx of this infant who also developed respiratory disease. So I think it may happen, these cases make a case for it, but still it is quite uncommon. We're not seeing this is not gonna be a big fear congenital infection phenomenon like we saw with Zika or like we saw with certainly other ones in our usual list. Okay. Another concerning thing that's gotten recent reports is the question of reinfection, because we've been saying from the beginning people can't use their serology to count on durability of infection, and reinfection is possible. There are two, again, kind of very strong cases that suggest that reinfection can occur. First one listed here was a case of a 25-year-old in Reno who had early kind of mildly symptomatic disease, was tested positive, had symptoms resolve, and had 2 fully negative tests thereafter. And then 48-day recovery, had new symptoms that was hospitalized and infected again. Now, Lynn just told us that there is this case of intermittent shedding, and so people thought that might be what that was. But with really close virology, they showed that these were 2 very different strains that just statistically highly unlikely that it could have evolved within him to be the same. So you can see on the right there, I'm not a virologist, but you can see there's the circle. They often present them in this way, very far from each other. These are distinct lineages. Same with a case from Hong Kong. This is a 33-year-old. There was a 150-day window between these infections, and he was screened actually returning asymptomatic in this case, but had a very distinct strain. So I think it occurs, but again, I think I don't want to overemphasize the case report thing. This is occurring after millions and millions of cases before we've had 2 well-documented ones. There are surely more undocumented cases out there, but suffice it to say, this does not seem to be a driver in our epidemiology while it does occur, and it shouldn't underscore our optimism about immunity following disease and vaccinations in most people. Any updates on treatment for children? We've had several guidelines that have been since published. I'm going to shamelessly call out one guideline by a group from the Sharing Antimicrobial Reports for Pediatric Stewardship. This is a kind of a stewardship leadership group of which Rachel Wadier and Steve Grabentine in our team were represented and helped develop those guidelines. The take home from then was that, again, knowing that kids have generally mild disease, we would reserve our treatment for respiratory disease for severe cases. We have evolved in our understanding of treating more aggressively for the MASC-like presentations with steroids, IVIG, and anakinra, and our team's evolved with that. But primarily, it's still supportive care. This should be the message to people. Certainly for people with mild disease, there's no yet any data around, although studies are going on for kind of early abortive treatment with different things. Right now, we are just not there, and certainly no role for prophylaxis either post or prior to exposure at this point. Okay, I'll wrap up in the next minute here. Steroids. As usual with this talk, I don't wait to do it ahead of time because there's new stuff that comes out the day before. And just yesterday, really important data was published in JAMA. There have been a number of studies looking at the potential role for treatment of steroids in the treatment of severe disease in adults. The recovery trial was halted early based on some promising data. That trial was then picked apart on many grand rounds and all over the country because it was a powerful effect in a certain subgroup and then trends in difference. And so people were really waiting to see more data, but that trial was stopped by its DSMB. And then at the same time, 3 other RCTs were also stopped. So we are in a, are we going to look at? So they've published here the results from the total of the 3 RCTs that we're looking at this, the DEXA-COVID, the CODEX, and the recovery trial, and then the REMCAP. I'm sorry, it's a 4th. And then the WHO published a meta-analysis looking at the results of all these trials, which is in the same issue. And that included then 1,700 patients that kind of was able to adjust for the partial follow-up by including them all together. They had, some of the numbers there, but to skip to the punch, they showed a sort of powerful effect of around an odds ratio reduction to 0.66. Of an overall effect on 28-day all-cause mortality. So hard outcome, the strongest for this kind of study to look at, and impressive. And it kind of puts to rest. Steroids are good for severe respiratory disease. I think there'll still be questions that come up about how sick do you have to get before you get your dose, et cetera. But the bottom line is we need to consider this part of our key armamentarium based on the data in adults and probably for the cases we need to in children. And I want to underscore the other big part about this is steroids are cheap and steroids are everywhere in the world, maybe overused, but in this case will be really, really useful in the treatment as this pandemic hits a continent like Africa where it's delayed, but it does seem to be going. Okay, I'm almost done. What are we doing here at UCSF? Just to let people know, we have a working group that meets weekly, including team members from the subspecialty services usually involved. We have a guideline coming out led by our emergency medicine department that will help with the triage. We are participating in 3 national registries. And we also have Mary Prawl, who's participating with a priority trial, which is kind of perinatal and maternal trial looking at immunology and transmission in exposed infants. I'll now hand it back to Naomi.
Okay. Sorry, can you guys hear me okay?
Yes, we can. Thank you so much. Sorry, I was trying to find my unmute button. So Dr. Bardock is next.
Perfect. Thank you. So I'll just call out one thing. We're running a little bit late. Panelists are answering questions in the question and answer section in case we run out of time for our questions. So there is some active work going on in that Q&A panel right now. So if people are posting questions, I'm going to be talking about particularly focusing on school reopening around a few brief. I speak from the perspective of a pediatrician and a parent, a doctor, and a policy researcher, which means that as a pediatrician or parent, I care a lot about the kids getting back to school As a doctor, I care about all human beings, and as a policy, so it's important to think things at once as we think about school reopening. And then, of course, the caveat: our understanding of this disease is rapidly evolving. What I tell you to research, although the theme be relatively cool. And finally, it's a team sport, so lots of thought partners and collaboration. COVID is we have to remember.
Naomi, you're breaking up a little bit. Can I suggest you turn off your video? So
Sure, great idea. No problem. Yep, let's see if that helps. Thank you. So unprecedented collaboration is what is needed. So just to briefly frame the school reopening conversation, we know that the COVID-19 pandemic has caused economic devastation and financial instability across all communities. You can see from the table here that there's limited illness burden in children, but families with children bear a larger brunt of the economic devastation, which is mediated through school closures. And I'm sorry, this table it demonstrates that what we focus on most often is we focused on the case positivity, et cetera. What are our hospitalizations? And what we don't do is we don't track the harms associated with the closures, with school closure. But I would suggest that as much as we have a dashboard that focuses on cases and hospitalizations, we should actually also create a dashboard that looks at school, the harms associated with school closure, whether or not our children are succeeding or not educationally and are safe at home, and the financial issues for the families as well. But the last thing to say is also teachers and educators are key partners. There's a false narrative that says that teachers and pediatricians are at odds here. There was a false narrative a month or two ago. That's clearly not true. Pediatricians and teachers are in it together for the kids. What's good for teachers is good for students, is good for families. And we have to have a united perspective as a society to try and figure out how to support kids and families and teachers as we think about school reopening. And the goal should be that we should have equitable school reopening and also safe. So we know more than we did in March. We know what works and what doesn't. And what do we know? We know a little bit about how children get COVID-19 or why they get COVID-19 so infrequently. I'm going to go swiftly through some of these slides because we're out of time, or we're running low on time. The implications. So ACE2 receptors are the entryway for COVID. Children, specifically elementary schools, less than middle and high school students, and who have less than adults, they just don't express the ACE2 receptor, and so there is no doorway for the virus to get into the body, and therefore there's less disease in the elementary age students. And then just a few things to highlight: the transmission is not common in children. It does happen, but it just doesn't happen as frequently. And it's particularly as you think about school-based settings, is opening up a school going to lead to more transmission within the school? In the children, it is just not common. There's a case study of a 9-year-old in France who had co-occurring influenza and COVID-19. He went to 3 schools. There were 80 contacts and there were no cases of COVID-19, but there were some positive influenza cases. Complementing that very, sort of striking, unique N of 1 story is there's a very large study out of Australia looking at 25 different schools going all the way from preschool all the way up to high school. They found that most of the school-based cases, which were very few, actually were from the community. In the school setting, the child-to-child transmission rate was 0.3%, child to staff was 1%, staff to child was 1.5%, staff to staff was 4.4%. Overall, the numbers are low, but the take-home point is that the staff to staff is 4 times higher. It's the adult-to-adult transmission that we really need to focus on as we reopen schools. We are at risk of, in our narrative, focusing on the children, and we need to focus on the adult-to-adult transmission to keep adults safe, and because adults have control over their own behavior in a way that that there's a fear that children will not. A brief touch on why don't younger children transmit as efficiently. And these are just practical considerations. They're, they have smaller lungs, therefore they have smaller clouds of viral particles. They have less severe disease. And so the theory is that because they have less coughing, they're going to have less spread. They produce less respiratory droplets, therefore they're going to have less spread. And then children are shorter than adults, kind of, very basic, but gravity pulls respiratory droplets down. And the major form of transmission that most people think about as for COVID-19 or SARS-CoV-2 is that it is a respiratory droplet transmission. There is also probably some aerosol transmission, but to the extent that it's the respiratory droplets, they go down, they don't go up. Children are short, therefore they're less likely to transmit it upward. A few things to call out though, as you noticed in that ACE2 receptor study, elementary was different than the older age groups. So high schools do seem to be different from elementary schools. There are two really good studies out of France early in the pandemic when the community prevalence was about 9%. There were no precautions in place during that time in the schools. And in the high school, they had 43% of teachers, 38% of students infected. In elementary schools, 7% of teachers and 9% of students, which reflects the community prevalence rather than the transmission that looks like was happening in the high schools. So the implication is that transmission does seem to occur in high schools, and the community prevalence was reflected in the elementary schools, which suggests that there was not transmission actively in the elementary schools. What do we know about what not to do? So as we think through what are our interventions at hand to help us reduce transmissions in a school-based setting, we see there was an outbreak in a high school and a middle school in Israel that reopened in mid-May. There was an outbreak in the school in late May that led to more than 150 infections in the school. It was a huge outbreak. And part of the story there is that there was a heat wave a few days after reopening. So they told the students they could stop masking. 2 index cases, which were students, were present during those 2 days of the heat wave with no masking, and they were symptomatic. You can see a picture of all the students in the classroom. This is when they were masking. They didn't have any social distancing in place. They had 35 students back in the classroom, and they had the air conditioning on and the windows were closed. So the implications about what not to do is we do know that if you don't wear your masks, if you're tightly squeezed in, if you're not well ventilated, it's going to lead to that kind of outbreak. So the really important pieces, masking, physical distancing, ventilation are all key. The symptom screening could have potentially helped, and that's another layer of what the public health principles are: symptom screening and then exclusion from school, get a test, and then come back. So how do we know what to do? How do we do it right? There's a couple examples of what happened in San Francisco this year. This summer, I did some work in an indoor camp setting where we found no documented PCR cases. And they did some really nice jobs. We watched the kids, this is kindergarten through 8th grade, masking nicely, stable cohorts, physical distancing, hand hygiene, ventilation, everything was in place, no cases. And then in another set of data that the San Francisco Department of Health presented was they looked at the outdoor camps with 3,000 campers in San Francisco, and there are only 2 camp-based transmissions. So there were, I believe, 38 cases in those camps, but only 2 of them were actually camp-based. All the rest of them were from outside of camp. And the 2 camp-based transmissions, one was staff to staff in the camp, and the other one was a child-to-child transmission. So the implications from these experiences is that it's possible to follow public health principles, and that can lead to limited, or in this case, no infections. And then one other case of doing it right. This is a recent article that just came out last week, 2 weeks ago now, August 21st. They looked at all of the childcare programs in Rhode Island from June to the end of July, 666 programs, almost 19,000 children ranging from 6 months to 12 years old. They used stable pods of 12, and then they actually increased to 20 on June 29th. They had separate spaces for every pod, no intermingling of staffs. There was universal masking of adults, but no requirement for children. Actually, even up to the age of 12, there's no mandate there in Rhode Island for that. They did daily symptom screening, enhanced cleaning and disinfection, and the classes closed if there was a symptomatic person. So that's actually a very high standard that that was not actually something that was implemented in San Francisco this summer. They had 52 cases, which was quite small, ended up being a 0.3%. But it did lead to, I think, that very high standard of you close if you even have a symptomatic person, that led to a closure of 89 classes and a quarantine of almost 700 children and almost 200 or 166 staff members. And then the other finding was that as the summer went on and they had increase of cases, their community prevalence rose, their cases increased because their community prevalence was rising. So in another, just the last couple minutes, I'm going to talk about a hot topic, which is, I think a lot of people, there's been tons of buzz around testing strategies. So I just want to, I've been working with the San Francisco Department of Public Health to help them think through their testing strategy around school reopening. And one really important intuition that that I think is helpful for people as they think about, should we do a lot of asymptomatic testing or not? We have to start with the baseline that symptom-based testing will actually probably lead to substantial testing, and why. COVID-19 symptoms are similar to many other viral syndromes, coughs, cold, sore throat, diarrhea. So if we say to ourselves, well, the kids are never symptomatic with COVID-19, that's okay. They are symptomatic with other viral syndromes. You know, almost every other viral syndrome known to children is going to look like COVID-19. So the current recommendation from San Francisco DPH, California DPH, are to do symptom screening and exclude symptomatic students or teachers from the school. Also, we know they get a lot of colds, 6 to 8 colds a year at least, and other viral syndromes as well. In order to return to school, they will generally need a negative test. And that is because otherwise you have to stay out for 14 days, for 10 days if you're symptomatic. And that's just, it's not going to be a good way to run our schools. Why bother reopening if people are going to have to stay out for 10 days? And that's true for students and for staff. So therefore, we actually will be getting a lot of testing, I think, just by the symptom-based testing alone. And then the other thing to say out loud is that there is an interesting analysis done by the New York Times actually, which says that, you know, because if community prevalence is high, you will get cases walking into schools. That's different than transmission that happens in the school-based setting, but you still will have cases coming into the schools. And this just basically shows, depending on your prevalence in late July, if you have a pod of 10 versus a school of 10 versus a school of 500, what's the how many cases would actually be walking through your doors. And the thing to point out about this slide is that this is overall San Francisco County prevalence. In our higher prevalence communities, you know, Bayview, Latinx communities, they'll probably look a little bit more like the Florida numbers down here. And so as we think about community learning hubs, which are, you know, safety net learning hubs for indoor learning for kids who have low access to computers or internet, we should be thinking about these numbers potentially more than just the San Francisco numbers. This is a study I wanted to call out because it's a UCSF based, including Dr. Ramirez and other folks, Dylan Chan, Christina Rosby, people from our departments here at UCSF. That was a great article that just came out in JAMA Peds, which basically helps us to begin to quantify if you have asymptomatic prevalence, that's what's here on the y-axis, what is it going to look, how does that relate to the weekly incidence of COVID-19? So as we go up in prevalence, we can, weekly incidence of cases, we can then try to actually begin to think about what percentage we're going to have of asymptomatic cases in our schools. And so how much testing do we need to do? What cadence of testing? How frequently should we be doing testing given these numbers? So that helps us with our modeling. So thank you for doing that paper. That's a very helpful paper. One other important piece that is also informing thinking around testing strategy is this very helpful modeling study done by Jennifer Head at Cal. And they looked basically at what is the proportion of each group experiencing symptomatic illness in the fall semester. It's a modeling study, but it's based on real data, survey data that they collected around contacts and how people are going to be having contact with the outside world. And they looked at these different strategies you see on the y-axis here, monthly testing of teachers and students, et cetera. You can see that even across high schools, middle schools, elementary schools, even weekly testing of teachers and students does not move these numbers as much as masking does and stable cohorting does. And if you combine these things together, it's very powerful. So even the stable cohorts by themselves can really change some things. So it's important as we think about testing strategies, where we're going to put money if we don't have access to a inexpensive and readily available test yet. And then just a few things. This is Michael Minna and Larimore analysis, which you may have heard about, which basically says frequent testing is going to drive down the R naught. It matters less about the sensitivity. It matters more that it's a frequent testing. And this shows daily, your reduction in R is going to be 100% reduction if you can do daily testing, which right now totally not feasible, every 3 days, weekly, and 14 days. You can see as you go out farther, this reflects the Jennifer Head analysis that the weekly testing is just not doing as much to decrease your R. And then the rapid turnaround piece is very necessary. This is the same type of graph, but it shows you for the daily testing, if you have a 0-day turnaround versus a 1-day turnaround versus 2 days, that the turnaround time drives things a lot. It's a big part of the story. So as we think about new testing technology, we need to get something that can be done frequently and has a good turnaround time. So the summary of the potential testing strategy is if we have adequate testing capacity, we should consider doing universal entry testing for students and adults, and that for older students and adults twice weekly asymptomatic testing, and then symptom screening and testing for effective surveillance testing. Effectively becomes a type of surveillance testing. Our mitigation strategies, masking, stable cohorts are still highly effective even without our frequent testing. And then enhanced testing should probably be considered in our higher prevalence communities. And our layers are key to our safety. So you have to think about the layering of all these interventions together. You can't just look at testing or just look at masking. You kind of have to put them all together. I'll leave this slide up for a second, but we're not going to have time to go over it. But you just, as we read the literature, there's a whole lot of swirl. And so I just usually try and help get a little bit of a framework for how people should be thinking about it. And I'll just say, you know, is it a biased sampling frame? And then what do we learn about transmission and about our current understanding of the prevention measures? And with that, I'll hand over to Elizabeth Rogers.
Thanks so much, Dr. Bardock. Dr. Rogers, bring it together for us by making sure that we promote our own well-being in all of this.
Fantastic. I'm just trying to start this. Thanks, everyone. I think what Naomi was getting to at the end as well about trying to support us all in reading the literature is also just more broadly, how are we all existing in the current pandemic? I think, sorry, I've presented to this group and others before that burnout in healthcare has been prevalent prior to March of 2020. And burnout has been defined by the National Academy of Medicine's Collaborative on Clinician Wellbeing and Resilience, as well as others, as being insufficient job resources to meet the job demands. And if you look through here, you can see many of us struggling with the appropriate resources even before coronavirus hit us 6 months ago. Now the world is all topsy-turvy. And in fact, in my own life, while starting school with 4 children, I try for it to look like this. Certainly in the last month, it has looked a lot more like this, which I'm sure it has for many of you. And so all of us as healthcare providers, as parents, as caregivers, and as humans have really struggled to deal with the swirl, as Dr. Bardock referred to, and how we can come to some semblance of control of it all. So there are many smart people who've actually tried to provide a framework for us to understand our own individual responses, as well as our institutional responses to a pandemic. And in fact, one of our former parents, who's also a psychologist and former Grand Rounds presenter, was an author on this paper looking at a variety of themes that can help us understand our own responses in terms of threat perception, risk perception, how leadership responds, individual versus collective interests, how we can improve our communication, understanding social context, and the fact that we've had police murders of Black men that have really escalated the not the certainly pandemic, but the long-standing stresses of racism in our society as well as in healthcare. So all of this sort of might provide some insight to you as to why you're reacting the way you are, and how as an institution we can help. When I talk about vitality, which is what some people call resilience or trying to prevent burnout, we talk about empathy and advocacy as being two primary ways to maintain vitality in the face of crisis. Empathy and advocacy both might be taken into account or considered as sort of both individual, institutional, and more broadly sort of in our external facing lives. Some of us may choose to do this in a really deep dive. When confronted with chaos, we're going to really focus in on one thing, and that's going to become where we put our energy and we get vitality from that. Others of us want to have increasing touch points, and rather than depth, we're going to use breadth to really try to stabilize ourselves in the world. Tate Shanafel at Stanford is a leading voice in clinician well-being. And this is one way to look at empathy, not just individually, but institutionally. And really, I would say, if you look at this, we're in the first aid period still. So we're still meeting basic needs of ourselves, of our families, of each other, trying to figure out how to provide support for all. And really what we do here at this time of first aid is going to indicate or help us decide whether we're going to go on to cope and recover. So this is, I hope, evident to you that there is a lot of this first aid that's happening in the community, but we also know there's a lot more that we can do. Some of us, rather than empathy or internal focused work, really look at advocacy, which is more of that external facing work. And so sometimes it's easier to help care for others rather than caring for ourselves. And in that vein, many of you have joined together to form CARES, which is the Collaborative to Advise on Reopening Education Safely. It felt like as pediatricians, helping schools reopen, whether that be virtually or in person, was very much in our lane. And so as Naomi has talked about, we've worked hard to make sure we can interpret the data, that we can collaborate and partner with our teachers and our districts. And we've had a lot of success in publishing a webinar series that's been viewed by quite a few people, and we have some guidance papers coming out as well. So I encourage you to check out our website, but also mostly I want this to thank you, because as a community, folks really rose and took on this challenge, which again gives us personal fulfillment as well. There's a lot of other advocacy going on, places where whether you're diving deep or needing breadth of touch points, you can turn to. This is just really an example, including the Child Independent Care Task Force, started by the Chancellor. Many of our folks, including Dr. Elizabeth Ozer, has been chairing that, Ted Rule and others. So our hope is that we'll be hearing some recommendations from them coming forth. Dr. Hirsch has convened an anti-racism task force for the department, which we hope to be hearing from soon, and many of you are involved. And for many of us, again, that gives us, really contributes to our vitality to feel like we can really confront racism in our work and in our society. The Caring for the Community Task Force, led by Dr. Kiati Brombat, Efrat Lelkis, and others. Many of you have been receiving some of those polls and surveys, so thank you. The Voice Project, which is working on patient and family voting, started by Daniela Brissett and some Oakland residents as well. So really a shout out to our trainees who often do push us in all the ways that we very much need. So I invite you to jot these down. There are a lot of resources in terms of building vitality. The psychiatry website of UCSF is one of the best. It really does consolidate a lot of resources that are available to you. But I also include here the National Academy of Medicine's initiative, the CDC in terms of specific mental health support, And then this last one is Tate Shanafelt's caring for healthcare workers. So again, for many of you, for me, sorry, that's it. Enjoy.
Thanks so much, Liz. And I didn't mean to cut you off there, but it is exactly 1 o'clock and you are our hero, because when I first asked this panel to come together to do something around an updated COVID-19, they thought they didn't have enough to talk about to fill an hour, and I should have known better, because they do. This was really great. We've managed to answer, I think, almost all of the questions in the Q&A, and we'll follow up with any outstanding questions, and I'm sure we can invite the same group of people back later in the year, because there always will be updates. Dr. Hirsch, will you end us?
Yes, thank you, Sandrine. I just want to thank our panelists for really outstanding grand rounds, and it really does open up a lot of questions. I wish we had some time to maybe we can find another opportunity to have further conversation about this, especially around this really important issue that is occupying so many people's thoughts in terms of opening the schools. And the data that Naomi reviewed really is very encouraging, I think, in regards to perhaps being more aggressive at opening the schools up, at least for elementary age students. So I'd certainly be interested in hearing more of a conversation about that, and maybe we could do that at another opportunity. But thank you, everybody, for participating, and we'll see you, is it next week, Sandrine?
Yes, we have a whole schedule lined up again. It's available on the wiki, and look out for emails from me and Charisse to get the announcements. But we're fully booked through the end of the year, so lots of really fantastic speakers upcoming.
Great. Thank you, everybody.
Thank you.